Hey everyone, this is Sarah Caudle, posting for discussion board 4, the treatment and pathophysiology of depression in children and adolescents. So I'll get started with the clinical manifestations of depression in children and adolescents. This was found in the assessment of adolescents for depression in pediatric nursing care setting, and it comes from the Pediatric Nursing Journal. They highlight that the clinical manifestations of depression in children and adolescents would include 3 key features, which are depression or irritable mood, anhedonia, and the inability to gain pleasure from activity for 2 weeks or longer. In addition, that these symptoms would be accompanied by at least 4 of the following symptoms, which include weight changes, insomnia or hypersomnia, psychomotor agitation or retardation, feelings of guilt or worthlessness, inability to concentrate, and thoughts of death, suicidal ideations or attempts. Additionally, some of the physical signs present in children and adolescents would include hygiene neglect, pale or tired appearance, a sad or irritable affect, and diminished reasoning for their age. Next, we'll be discussing the pathophysiology of these clinical manifestations of depression, and these come from Adams and Urban in our text. They highlight that there's several key puzzle pieces that all play a role in depression, and they all may play together, or maybe one or more factors. The first is the biologic factor, which highlights that abnormally low levels of neurotransmitters like norepinephrine, serotonin, and dopamine specifically are related to depressive symptoms. These are all found in the limbic system, which is responsible for regulating mood. Hormones also play a key role, particularly the endocrine system. We know that high levels of serum cortisol are found in over half of the patients that have depression. Cortisol is what's responsible for mobilizing the body in the fight or fight situation, and is thought to deplete serotonin levels, which lead to depression. We also know that genetics may play a role. Data suggests that you're more likely to have depression if you have a first-degree relative that has depression, so a sibling or parent. And lastly, environment seems to also play a key factor or play a key role in depression. Stressful events can trigger or be the catalyst for depression. In children, those can be loss of a loved one, physical, sexual, or mental abuse, separation from a parent, or the mental illness of a parent or family member. And now we'll move on to the pharmacological action of drugs that are used to treat depression. As in general, I guess the class of drugs are antidepressants, and they seek to restore the balance of neurotransmitters in the brain. There's 4 different classes. 2 of them are a little more traditional, and that is the tricyclic antidepressants and the MAOI inhibitors. So the tricyclic antidepressants, or TCAs, act by blocking the reuptake of norepinephrine and serotonin. These are not as highly favored as they have frequent adverse effects. The monoamine oxidase inhibitors, or MAOI inhibitors, block the actions of MAO, and that's an enzyme found in the liver which inactivates the natural monoamines in the brain, such as norepinephrine, dopamine, and serotonin. This one is also has an adverse side effect, specifically which causes a hypertensive crisis when it's combined with foods high in tyramine, and those are found in a lot of common foods, meats and fish, vegetables and fruits. So a very strict diet would be important when taking this medication. So therefore, this may not be a good option for children and adolescents. One of the newer class of drugs that was developed as a result of TCAs and MAOI inhibitors is the selective serotonin reuptake inhibitors, and those act by their namesake. They block the reuptake of serotonin, which prevents depletion of serotonin. So this class of drug has gained a lot of favor due to the low incidence of side effects compared with other classes. However, with all of the classes, there is a black box warning because especially for children and young adults, as they increase the risk of suicide. That's thought to be linked to the increase in energy levels in the first few weeks to months after taking any of the antidepressant medications. I will mention one of the drugs within the SSRI class, and that's Lexapro, and that was approved specifically to treat children ages 12 to 17. There is a miscellaneous category of antidepressant drugs, and those are serotonin, norepinephrine reuptake inhibitors, norepinephrine and dopamine reuptake inhibitors, norepinephrine reuptake inhibitors, and combined reuptake inhibitor and receptor blockers. Again, with all of the drug classes, it's important to know the black box warning which exists, particularly for children and young adults, and monitor for any of those signs of increased that threat of suicide. Thanks. Looking forward to hearing the rest of you guys' assessment of depression in children and adolescents.